Hello everyone, I'm Catherine and I'm going to tell you about some preliminary data we've collected from magnetic resonance guided focused ultrasound surgeries treating essential tremor. The lesioning target is the ventral intermediate or VIM nucleus of the thalamus. VIM lesioning interrupts the dentatorubothalamic tract, which is involved in motor control. We know that the VIM nucleus contains kinesthetic cells. On the right, you see the firing trace of a cell responding to the movement of the wrist. Proprioception comprises position sense and kinesthesia, and so VIM lesioning likely impacts proprioception, but this effect has never been quantitatively measured. Our goal was to assess the effect of magnetic resonance guided focused ultrasound VIM lesioning on proprioception in essential tremor patients. Because of the role of the VIM nucleus in kinesthesia, we expected this lesioning to disrupt proprioception. In order to improve the safety of focused ultrasound VIM thalamotomy and to avoid adverse events, we must first know the surgery's side effects. It's important to note that, although proprioceptive changes have not been quantitatively assessed, we know that gait disturbances, dysmetria, and disequilibrium are common side effects of VIM lesioning. Data were collected using the kin-arm exoskeleton. The patient is seated, arms are supported, and free to move in the horizontal plane only as the patient completes tasks. The data were collected pre-operatively and then at 3 follow-up time points. For this analysis, we only used up to the 3-month time point in order to have a larger, consistent sample size. There are 2 tasks analyzed here. In the visually guided reaching task, the patient sees the position of their hands and they move their hand to match the target. In the kinesthetic matching task, the arms are hidden. The robot moves the tested arm and then the patient must simultaneously mirror match both movement and position. The raw data are transformed into Z-scores based on age, sex, and handedness match controls. There are a number of different parameters that we get from these tasks. Here I'm going to show only a few of them. In the visually guided reaching task, posture speed is the speed of the hand when it should be still, and so it describes tremor. As expected then, posture speed for the treated limb decreases significantly following the surgery. On the right, you can see an example of a movement trace from a patient from pre to day 1. If you compare the two, then at the end of the movement, you can see the decrease in tremor. Movement time is the time the patient takes to complete the task. Movement time for the treated limb increased significantly following surgery. It's unknown whether the increased movement time occurred because of the novelty of tremor decrease or because of dentatorubothalamic tract interruption. It seems that the movement time recovers by 3 months, so this may indicate there is a required relearning in the treated limb. In the kinesthetic matching task, path length ratio describes how close a patient's movement is to perfect. For example, if the right arm is being tested, then it is moved by the robot in a straight line, and the left hand has to match that movement. Path length ratio then quantifies the ability of a patient to match the robot's movement. Note that there can be an undershoot or an overshoot, so the ratio can be below or above 1. Although there are no significant changes immediately following the surgery, path length ratio decreases significantly between 1 day and 3 months. These results indicate that there is, over time, some change in a patient's ability to match movement. Note that although this one low time point at 3 months looks like an outlier, there is still a significant result even when that patient is removed from the analysis. And further, if we look at the 1-year data added in, we see that the trend of decreasing path length ratio continues. So, as expected, posture speed decreased following surgery, which indicates a decrease in tremor. Movement time increased. On this point, it's important to note that a transient difficulty in using the treated limb after VIM thalamotomy has been previously described when different lesioning modalities are used. Contrary to our hypothesis, there were no immediate changes in proprioception-related parameters following VIM lesioning. There could be a few explanations for this. First, lesioning might not disrupt proprioception, which means that the gait and other disturbances we see are not related to proprioceptive deficits. Or, if we're trying to pick up on small changes, our sample size might be too small to clearly show what's happening. Or, we could be missing changes because of the inherent limitations of the kin-arm. For example, the fact that it measures only in a single plane might lead to failure to detect proprioceptive deficits in this patient group. The next steps then are to collect more data at the 1-year time point, and then we can assess whether there are any longer-term changes. Thank you.